do occur in non-tertiary or rural birthing centres as a routine birthing place. From some 119 birthing centres across New South Wales, from very, very small, from a few planned delivery birthing centres, such as Westmead, where I work, which is 6,700 deliveries, and we have a neonatal admission rate of around 1,200. So nice obligatory shot of Sydney Harbour. Less glamorous is Westmead Hospital from the air. So the known unknowns. So our work focuses not just on first world intensive care support, but also resuscitation across the world. And the majority of the need is in the developing world. Some 2 to 8% of babies, and there's 145 million babies around the world born annually, require resuscitation / stabilization. Now, in the developing world, that's more positive pressure ventilation. We all know that asystole, bradycardia, and apnea at the time of birth require lung ventilation as a primary assistance in deference to adult cardiopulmonary arrest. So it's crucial that the provision of manual inflations by some device occurs effectively. And this can be from very, very simple mouth to nose or mouth to mouth, tube to nose, a self-inflating bag, a T-piece, or up to, in fact, using a mechanical ventilator. So what we do know is that mask leak via some manual inflation device with mask and a device is common. It's often very large in magnitude, and it's unrecognized clinically, and it may hinder the resuscitation. And I'll show you some evidence that's a bit alarming, that there may be a complete failure of systems and unknown to the resuscitator. So delivered tidal volumes and minute ventilation, we all do this once a baby's in the intensive care unit. We've got a baby connected up to a ventilator with an endotracheal tube. We measure tidal volumes, we look at the leak on the ventilator, we look at the minute ventilation. This is all standard practice, but we're not doing it in the delivery suite. And should we? Well, clearly there's evidence from Bjorklund's animal study that 6 excessive tidal volumes in a preterm model, animal model, caused dramatic changes in the lung with initiation of lung injury that would lead to bronchopulmonary dysplasia or chronic lung disease. Airways obstruction in preterm and even term newborns may be a lot more common than we recognize, and very difficult to recognize. So there's a profusion of devices in each category to provide positive pressure ventilation with little or no data to support which to use. So the unknown unknowns are, well, is there one device that can rule across the whole of our resuscitation scenarios? Should the Neopath be the go-to device for a preterm baby, a term baby, or an infant? Now, why I've included infants, because we're all neonatal pediatricians, because all of these devices are actually rated up to 10 kilos. So also, is the performance of different infant resuscitators by class and by brand the same? So do they all provide the same ventilation? Given the same lung, tubing, and pressures, do they provide the same delivered ventilation? Are they safe? Now, lastly, in Australia, we have the Therapeutic Goods Association, and we've got the FDA in America, in our 2 countries, to approve life-saving inflation devices. But do they actually safeguard our patients? So our research is around understanding the biomechanical properties of devices, and we class them as a self-inflating bag, which is a flow generating, pressure generating device without any requirement for pressure or even extra oxygen. You can obviously use it with room air. T-piece resuscitators are flow dependent and pressure limited devices. They're basically a very simple ventilator without all the bells and whistles, which is important, as you'll see. Then we have anesthetic bags, and if with the American NRP guideline, you'll see that the hyperinflation, mercury medical hyperinflation device is listed, which is a hybrid between the T-piece and an anesthetic bag. We also have been looking at masks in terms of their hold and whether they're similar in terms of their functionality, and laryngeal mask airways. And you can see listed the other areas of our research. So you'll be pleased that I'm not going to knock through all 4 studies, but I'll touch on two pieces of work. So there's the newborn self-inflating manual resuscitator. This is called a wordy sort of title, Precision Robotic Testing and Safety. This was published in Archives Fetal Neonatal last year. Then our TVs Resuscitator work. We've got 2 papers last year, the TVs Resuscitators, how do they compare? And hot off the press, it's just in online first in archives, TVs Resuscitators, can they provide ventilation in low compliant lung model? So the newborn self-inflating manual resuscitators, precision robotic testing. Across the world, the self-inflating bag still is the most common device that is needed and the most appropriate device to provide lung inflation for babies not breathing at birth. And the Lancet series some years ago, the most recent one, Every Newborn, estimated there were at least 250,000 babies who appeared stillborn who would survive with some basic resuscitation. Now, various NGOs have implemented training programs helping babies breathe, PATH, USAIDs. And self-inflating bag brands have been recommended based loosely on their stated compliance to the ISO standards, International Standards Organization, without any independent performance testing. So for those that lead a very sheltered life and read the international standards, this is it for manual powered resuscitators. It's 1065.1. These are very slow to update. But in this, and the most recent one, there is a gap between physiology and available equipment, specifications and discrepancies amongst the existing standards, professional association guidelines. So what is the standard? Well, the standards actually are for less than 5 kilos and greater than 10 kilos. In fact, there is no international standard between 5 and 10. But under 5 kilos, it simply says that your self-inflating bag should be able to provide a minimum of 20 mils given a stiff lung, which is 1 mil per centimetre of water, and a very high resistance of 400 centimetres of water per litre per second. And they don't specify how hard you squeeze the bag or what sort of distance you squeeze the bag. So what does the clinician expect in a self-inflating bag? Well, a small squeeze to give a small breath for a small patient, a starting point. If the patient's bigger or sicker, you may need to squeeze harder or a larger distance to generate a larger tidal volume. So we set up a study to examine this characteristic, a dose response of squeezing the bag to give a delivered tidal volume by incrementally the compression distance. And we built a robot to do this. We went over the international standards in terms of testing criteria because we believe that they're not adequate, and I'll show you why. So we had 4 a priori pass-fail criteria. The first was to provide, the system should be able to provide a minimum safe tidal volume for an infant, the small sort of patient that we'd find, somewhere between 5 and 10 mils per kilo. So for a 500 gram preterm neonate, must be able to give 2.5 to 5 mils. If we had a box of 10 of these devices, that they should all work the same. So this is the average coefficient of variation in volume delivered over a compression distance per device and model. We call this the batch test. The third criteria is that the pressure release valve designed to prevent excessive pressures hitting the baby should work, and it's set an international standard at 45 centimeters of water. And so we set our system to work out if 99% of delivered inflations should be less than the pressure limit. Lastly, if you're squeezing a self-inflating bag, that something should happen before half of the distance of the bag is squeezed. So I won't labor this, but basically our robot was set to squeeze at a tiny distance, then incrementally increase after 40 inflations at each set distance. We had a set rate of 60 inflations per minute, of 0.5, 1 to 1 IE ratio. We had a Drago test lung, which was a minute of water, as a leak-free system. We collected the data into the Florian Respiratory Function Monitor, analysed it in the GROW Spectra Data Analysis Program, and we looked at inflation volume by compression distance and the delivered peak pressure, rate, and minimum pressure. Now, so this was the first 8 of the 20 brands we looked at. You can see the geometry varies, but you're all familiar with these sorts of devices. So this is our robot. So our robot was a 2-stepper motors. We measured the forces generated with our own hands, a standard hand, across a range of pressures, and we replicated those forces in this robotic system. So this is the group spectra data for those that are familiar. Have I got a pen? Where's my marker pen? Can you see? Can you see my mouse?
Yes.
Pointer.
Yeah.
Great.
Can see.
So flow, pressure, and delivered volume. And you can see here that this is 40 inflations at a very tiny distance, which is in fact 15 millimeters, and then it steps up to 20 millimeters. So this, I'll just show you a video of, this is a Liddell on the left. This is a Liddell self-inflating bag. It's actually a recycled, reusable system. And this is a brand new BesMed, which is internationally available. Both are being squeezed. 100% simply means you squeeze the bag until there's nothing left. It's completely collapsed. You can see that, in fact, the test lung with the BesMed is not actually moving at all. This would represent a complete failure of the device to provide any positive pressure ventilation to the patient. Has everyone got the video? Has it come through the Zoom? Okay, no time lag.
It's a bit jerky, but you can see it there, mate.
Okay, so right. Oh, so we've across the 20 brands that we examined, we examined 173 individual self-inflating bags. Every one of them passed the international standards. Everyone. Our robot delivered 48,493 delivered usable volumes, those more than 2.5 mils. 2,200 roughly delivered volumes or unusable. And there was something like 16,856 compressions where the self-inflating bag just didn't deliver any volume, as you saw in the video. So 10 of the 20 internationally available brands failed our testing methodology and failed spectacularly to the point where the patient would receive no volume. 2 models could not provide a safe minimal volume, which meant that they could make for 1 kilo bag. Injurious their safety pressure limit valves and could deliver very dangerous pressures to the patient, and in fact represented 6% of their inflations all up. 5 models had excessive coefficient of variation, and I'll demonstrate that in a sec, and 3 models simply couldn't deliver volumes until more than half the bag was squeezed. So the study found alarming inter-batch variability. In half the brands that failed our system, or all the brands that failed our system, a box of 10, you'd pick unit 1 and unit 10, and they would behave differently. This was all leakage of the patient control valve, mostly listed as a duckbill. So that pressure, the growth spectra waveform I showed you earlier, this is a compressed study. So in fact, we've got inflations going at all sorts of distance. This is nothing happened at 15 millimeters, then it stepped up to 20 millimeters of squeeze of the bag, all the way up to the last point, which is 60. For wall-to-wall collapse of the self-inflating bag, it's 80 millimeters on average. So this is a good brand. You can see this is a bad brand where nothing happened until half the bag was squeezed, but then it seemed to have a symmetrical volume delivered. This was a very bad bag where nothing happened until nearly the bag was completely squeezed, and suddenly it was shifted 15 mils. So if you had a half a kilo sized baby being resuscitated with this, you deliver 30 mils per kilo. If you had a 1 kilo baby, it'd be 15 mils per kilo. Obviously, not a good volume to be delivering. So we won't label this is in our paper, but the take-home message, a lot of internationally available brands are not fit for purpose and potentially unsafe. So this is a box and whisker plot where we averaged each brand. So we had, usually 10 units in each brand, and you can see with compression distance and box and whisker, the first 10 brands that all passed, it was a very tight curve, and there was a relationship between squeeze volume and delivered volume. Then things started to get hairy, where the box and whisker plots indicated great variability. And then in the last few brands, and these are the worst brands, nothing happened very early, and very great variability in delivered volumes is on average across the number of units we tested. So this is one brand. This is the Hisner brand, and these are 10 individual bags and their response to being squeezed. You can see unit 1, 4, 8, 9 and 10 effectively completely failed, yet a couple of the units actually performed reasonably okay. This is the interbatch variability factor. So looking at the potential for those that had a failure of their overpressure limiting valve, you could generate very high pressures, as you can see there with this box and whisker. So our conclusion with this study was that half of the self-inflating bags examined failed our testing methodology, despite currently all of them passing the international standards for delivered ventilation under 5 kilos. We concluded that the current standards are not fit for purpose, essentially, and need revision. In fact, we're in negotiation with the standards, international standards as we speak, to revise the testing protocols. So the unknown unknowns are, do the international standards for life-saving manual inflation resuscitation devices discriminate unsafe from safe devices? And we believe they don't. Now, our local government has acted on this data and has restricted sales of the brands that are poorly performing. So what's going on? So this is a cut-through diagram of a self-inflating bag where there's squeeze of the bag and there's forward flow into the patient, indicated by the arrows. And crucial, the exhalation port needs to be blocked off. And then where the baby breathes back, or there's a passive exhalation from the patient's lungs, there's a prevention of rebreathing in the valve simply because the ductbill has closed. And this is the functionality. What's going on in the fault condition, the seating of this circular silicone valve simply isn't coming down to block off the exhalation port. So gas is going preferentially to the atmosphere, not into the patient's lung. So moving on to TVs Resuscitators. This paper is called TVs Resuscitators, How Do They All Compare? The background is the TVs Resuscitators, we all know, and predominantly Neopath has become extremely popular as a primary resuscitation device. And also it's actually labeled as an infant resuscitator, and it's rated up to 10 kilos. Clearly, a TVs resuscitator depends on gas flow. Some of the systems require power, if they're inbuilt into a resuscitator. They can provide PEEP during positive pressure ventilation or CPAP. There's a perceived use which may actually not be in truth, be inbuilt into infant warmers. And there are now low-cost units available. And in fact, there are systems now that don't even require a driver box. So literally you plug in an oxygen cable or a flow cable, flow tubing, and it doesn't have a dial box to generate the pressures. So its use is largely focused on preterm birth, and ILCOR clearly recognises that there's insufficient evidence to recommend one device over another, but in general, TVs resuscitators have replaced self-inflating bags in predominantly the first world or the developed world. And in Australia, our ARC guidelines recommend the use of TVs resuscitators over flow-inflating bags with little evidence. So the 2015 ILCOR guidelines recommend the use of PEEP during preterm resuscitation, but make no recommendation at all on term infants. The use of CPAP is recommended in preterm infants with respiratory distress as a primary system rather before intubation and positive pressure ventilation, as we know. And 2010 ILCOR guidelines indicate that breathing with difficulty, CPAP for all babies with breathing with difficulty. There's no evidence to support or refute the use of CPAP in term infants. So the starting pressures for a TVs resuscitator, 20 to 25 centimeters of water for a peak inflation pressure, 5 centimeters for PEEP for all infants. That's in the NRP. So does one device fit all patient sizes? So we've got here the largest newborn infant that we could find. It's around 7 kilos. The 10 kilos is an infant, and in fact the Neopath is described as a pediatric as well as neonatal resuscitator. Now, Neil Feiner published in 9 years ago now some alarming findings from real video resuscitation using a Neopath, with a Neopath, that there were a significant number, around 7 to 10% of their resuscitations. They noted an inadvertent rise in positive end expiratory pressure. You can see a graph. This is a compressed study of actual pressures here. In fact, the baby was being generated on pretty high pressures, 35 on 5, but there was a gradual rise in the PEEP up as high as 15 centimeters of water. Neil thought this was due to, during the resuscitation, that the dial was inadvertently rotated during the resuscitation, allowing a rise in the base pressure. And it diminished and they reset the PEEP. This was alarming. So we believe that there's a different explanation for this, and it's due to the basic biomechanical properties of a TVs resuscitator. This is work from Drevhammer et al., looking at the imposed work of breathing, which is secondary to resistance, across a range of devices providing CPAP. And you can see that the Neopath, particularly with a flow rate of 8, has a higher imposed work of breathing. So the Neopath, if you cut it in two, and this is a diagram from Fisher and Paykel, there is a conical disc, and as you screw the valve down, you decrease the area of E-flow. And this provides resistance and thus provides the level of PEEP. sticking your finger over then generates the whole flow into the baby. So the characteristics of this is simply the inflow and the expiratory resistance. So in this study, we also looked at one other new form of T-piece resuscitator that does not have this characteristic. So coming back, not only the Neopath, but the Dragar and the GE and the Atom and several other brands, all other brands have this similar methodology of having a screw down knob, reducing the flow by increasing expiratory flow resistance. The RPAP is a new system that works similar to the infant flow driver, which is a fluidic flip. There's inflow, there's a little aerodynamic bevel that allows reduction of flow based on whether you include the exhalation port to deliver. It's a very small unit, quite similar to in design in terms of a PIP and PEEP to other T-piece resuscitator units. So a study designed to compare measured ventilation across 5 devices, the Atom, Neopath, RPAP, and 2 inbuilt into the warmer, the GE Panda and the Dragar Resuscitator. In this study, we looked at a range of compliances from a preterm infant with stiff lungs of 0.5 up to a term infant who had normal lungs, compliance between 4 and 5 centimeters of water per mil. In this study, we had one set inflow, 10 liters per minute, PIP 20, PEEP 5, and a rate of 60. And we examined what happened with a range of test lung and respiratory function monitor data. So this is the 5 devices, the Atom, the GE Panda, so that's the Dragar, the GE, that's the Neopath, there's the Atom, and there is the RPAP, and that's the test lung system, which is mixing test lung and the Florian respiratory function monitor. So graphically, what we saw, this is the 5 devices, their pressure waveforms with the very low compliant model. Here is pressure waveforms at 5 centimeters of water, a very compliant lung model. And this is the G Panda, this is the Dragar, and you can see RPAP, and we've got the Neopath and the Atom across on the A5. There's an interesting note, which is a pressure spike. So we set the system up per manufacturer's guidance on 20/5 using their circuits, and you could see that there was a pressure spike seen with the inbuilt systems Dragar and the GE Panda. When you got to 5 centimeters of water, what you saw was that they all struggled a bit to get up to the set PIP of 20. But in fact, there was this phenomenon of auto-PEEP or inadvertent end expiratory pressure that's seen with all models except for RPAP. RPAP fell back to the baseline pressure. So we examined 1,864 inflations and tested it. And in a nutshell, this is graphically seen. So this is our set PEEP, rise inadvertent PEEP seen with all models across biomechanical system. With the peak inflation pressure, the dotted line is what we set the system before we did the study, and you can see that the G Panda and the Dragar resuscitators had this pressure spike. And that in fact, as you got up to 5, most systems had a drop off in not quite achieving the set pressures. And this led to a linear response in volume with the RPAP, and there was sort of a flattening of the curve in terms of delivered volume. across compliance values. So does this matter? Is this just a blip that we saw in a test lung situation? Well, this is George Schmalz's group's data. This is actual baby resuscitation data. They used the Neopath on the GE Panda circuit. So they had a Neopath circuit attached to a GE Panda, and they set this resuscitation up to be 30 on 5, and they saw the blip. They didn't actually comment on it. This is data from a human infant study that we are currently doing using the NM3 respiratory function monitor, and here we've set the baby up to be a mask ventilation of 20 on 5, and you can see that we're getting this pressure blip with the GE Panda resuscitator. So our conclusion showed important variation in delivered ventilation from set values, and which is inherent to the TVs resuscitator device design characteristics, particularly across a range of compliances. That device-generated inadvertent PEEP is real and can impact on your babies, and needs to be considered, particularly when you're ventilating an apneic term baby. Low compliant test lung models are further planned. In fact, we've done it. So the unknown unknowns, the standard TP device is using screw-in expiratory resistor to deliver the required PEEP at risk of significant inadvertent ones who have got normal lung compliance. A new system called RPAP using a biphasic flow is free of the risk of inadvertent PEEP with compliances greater than 3 mils per centimetre of water and is pressure stable. Now, we've recently, hot off the press, this is first online with Fetal Neonatal Archives. We've further expanded this data. When we first presented our study in PAS and the neonatal resuscitation group, people said, well, okay, pressure spike, what does it mean? Does it really impact on the baby? We're really interested in volume. So our next paper examined the impact of volume on GE Panda resuscitator. And I haven't got time to dig into it, but it is first online access now. We compared the Neopath as the baseline value here, and then we looked at the Drager and the Panda and the variance of the pressure from set value, and this is the spike. So with and the spike in the pressure value actually is greater in lower pressures than with than higher pressures. It actually makes a big difference in delivered tidal volume. So compared to the baseline value of a Neopath, the tidal volume was 70% larger at a pressure of 15 on 5 with the Drager, the Drager resuscitator. And you can see with the Panda wasn't quite as bad. You had a 35% increased volume given identical lung compliance, identical tubings. So this pressure blip does impact as a higher tidal volume delivered to the patient. So this has all led us to concluding that we need to have a way of monitoring leak and monitoring volume delivered in a resuscitation. Colin Morley, one of my mentors, is really upset that the Accutronics Florian Mark II has been removed from the market by the new company that's bought them out, Vario. So in response, we've developed a tiny battery-driven respiratory function monitor that shows leak as a traffic light system and gives you the exhaled tidal volume as a way as a way forward. It's still in the prototype development, but we believe this could be an exciting improvement on how we resuscitate both in the first world and in the third world. I think at that point I'll open up for questions.
Great. Thank you so much, Mark. If you can end your screen sharing, screen show.
Yep.
Okay, brilliant. And we'll change to everyone. Okay, so while I'm trying to get the questions up, if anyone wants to ask a question for Mark and Murray, please unmute yourself, and if you have a video, just show your face. There's no questions on the screen so far. If you're shy, just type it up. Any questions, or is everyone?
So Mark, this is Mark. This is
hi,
Srini here. Hi, Mark.
Hi, Srini.
How are you? So
we can see you, Srini.
So now just checking. So what is currently used in Westmead, NICU?
So
your clinical practice.
Yeah, good question. So several years ago, we noticed a fairly alarming rise in the rate of term pneumothorax.
Yep.
Now, because we have been spending 10 years training everybody endlessly and studying them endlessly with mask grip, with respiratory function monitors, we believe that we've got mask sleep much improved. Paradoxically, using the Neopath in term resuscitation, we were seeing a rise in pneumothorax. Now, this has been seen in Japan using the Mercury Medical Hyperinflation system, which is basically a TP system. They've reported in archives 2 years ago a rise in term pneumothorax, and recently the Americans, Murray, who was the report by? That was
Myra White.
Yep, has reported a similar rise in term pneumothorax with TPs resuscitated. So we've gone to change our first offering of resuscitation device. So 34 weeks and above, we use the Ambu self-inflating bag with a PEEP valve and with a manometer built in. And below that, we use a Neopath TPs resuscitator.
Right. And what is the PEEP that you set for the Ambu bag normally for a term baby?
Well, 5.
Yeah.
Yeah. I mean, we know there's no great evidence for but we have a standardized way of providing it for everybody.
Yeah. No, because what in practice, what happens is most of the junior staff, when they go for resuscitation, because they're so tuned to preterm babies, they go and probably set a high PEEP and everything, even for a term baby, and then you end up with the pneumothorax and everything. So yeah.
Well, and certainly in the Australian context, we've got all of our paediatricians usually go through a neonatal unit to get their hands-on resuscitation experience. And there's usually a Drager or a Panda resuscitator in most A&Es when an infant comes in, and the default position, as far as we can work out, is if an infant will fit on a resuscitator, it's a handy spot to resuscitate. So they will reach for a Neopath as the first line device, and that may not be an appropriate system, really.
Yeah.
One of the questions from our fellows is, what pressures would you recommend for the extreme preterms to be set during the initial resus?
We would start with 20 on 5 or 18 on 5, 30% oxygen, unless we're torpedoing, and just work up. What's dramatic is that a lot of term babies, once their lung is inflated, require very low pressures, 15.
Yeah.
And working on the Melbourne group's knowledge, that the transition from a fluid-filled lung to air-filled and self-ventilating, particularly with an asphyxiated baby who's not breathing at all, we've got dramatic changes. That the term baby, even though they might not have any abnormality of the surfactant system, will have very low compliance, equivalent to an extreme preterm infant, around 0.5 centimeters of water per mil per centimeter of water, when their lung is still pretty full of fetal lung fluid before that's driven out. Then they transit into an aerated phase. So in fact, the potential for the Panda and the Drager to impact with the blip with low compliance, then as the lung aerates, their compliance changes, and then the auto PEEP, that's a double whammy potentially, and might also lead, we hypothesize, to the greater risk of air leak in pneumothorax.
Thank you. We've got Tetsuya from Japan online. Could we find out what you guys do in Japan?
Oh, hi. So,
Hello.
are you asking resuscitation in Japan for the small baby?
For the big ones.
Oh, so for big one, the term baby.
Yes.
Oh, okay. So I don't know that so general management in Japan, but in my hospital and many hospitals in Tokyo, we are using the flow inflating bag, the anesthesiology bag, and I think usually we. Sorry, question is for the CPAP or PPV? Are you asking about the management of the CPAP or PPV?
So, yeah, so the paper that we've read from one of your colleagues,
Ishikawa,
and I can't remember which town, city he lives in, that the before and after your recent Japanese resuscitation guidelines around term respiratory distress, it was the hyperinflation system that had it looks like an anesthetic bag, but it's got a dial that you can also
flow control valve. Yeah.
A flow control valve, which is an expiratory resistor equivalent to a Neopath. And we hypothesized that in term babies is causing a risk of air leak because of it's all time constant. So if you've got a normal compliant lung, for it to passively deflate, I mean, you need 2 or 3 time constants. And the time constant of that lung is insufficient, going at a rate of 60 to deflate. So you breath back, you get a rise in your delivered PEEP. You set your PEEP at 5, but in fact it might rise as high as 10 or 15. And we've seen this in actual resuscitations in apneic term babies who are intubated, and we've brought them back on a Neopath. We set the system on 16 on 5, and one of my other consultants was alarmed that they couldn't get the PEEP lower than 12. They thought there was something wrong with the Neopath, but in fact, you can get it back down to 5, but you need to drop your rate to below 20, possibly 15. That may not be appropriate, particularly in an asphyxiated baby. And that's why we've gone to using back to the future and using a self-inflating bag to provide term baby resuscitation. Now, of course, we don't have yet a solution for the self-ventilating but term baby who's got respiratory distress and needs CPAP. We either stick them on our transport ventilator with good old-fashioned ventilator delivered CPAP, but in more general, we are still using a Neopath in transit. But if it's a face mask system, hopefully the seal isn't too good, and there's a natural pressure release valve to prevent the breath stacking.
Thank you. John wants to ask a question.
Mark, can you hear me?
You can work it out. Well done, John.
I can hear you. I can't see you. I don't know where you are in the schema of. Oh, it's probably you're on page 2. Hi, John.
Yeah, I'm in. I'm travelling overseas, Mike.
Are you?
No.
Mark, cool. How are you?
Mark, that's a great talk. Thanks. And I'm sort of thinking there may be a role for more stimulation of some of these babies before, so they can establish their lung volume before we move in with the devices. I don't know.
Yeah, absolutely. Yeah, little is better. Yeah, so stimulation. The delay. Look, this is only pertaining to if you are forced to use some form of manual inflation. So, I mean, clearly delayed cord clamping, stimulation, harsh language, everything you can get the baby to do its own breathing is the better, really.
Yeah, and the other question, that resus right looks fantastic, and the World Health showing some interest in that.
Well, we're still in prototype development. I mean, I couldn't show you the full-on video because we're sort of battling IP with the university at the minute. But look, we hope to have a unit that we can get out there as a device to sell for training, just start with, and then hopefully, look, we can produce this system cheaply enough to mass produce it and get to everywhere in the world. Hopefully, that's the aim. But I mean,
Fantastic.
I think it will come around a sort of new way of thinking that, first of all, eliminate your leak, and then work on the volume, the exhale tidal volume. Now, I pose a question to everybody. So we're all neonatologists and high end, and you're all very interested in sort of research because you're on this call. So you're probably all very familiar with Colin Morley's and our colleagues in Melbourne with the mask leak in mannequins and subsequently in human infants as well. And it's very hard to determine how much leak you've got looking at the chest wall rise. So and we're all trained to escalate. So if we've got a Neopath and we are, we're getting poor response.
We've lost you, Mark. Yeah.
No. Yeah, sorry. My phone went off. I just had to kill it. I have put it on mute, but it went on. So if you poor response, baby bradycardiac, still blue or white, and you're escalating the pressures as you're trying to do, but in fact you're battling mask leak and you can't see how much mask leak you've got. You then intubate the child because of poor response. You are bypassing the leak. How many people will wind back on the pressures on the Neopath dramatically? And I think the answer is that it's very common, particularly with less experienced staff, that they've escalated the pressures, the PIP with the Neopath, combating an element of airways obstruction and mask leak that they can't recognise, they can't measure, and they then intubate the child, they get the tube in the right spot, and they transfer those step pressures that they've gone up to, say 35, 40 on 5, onto the ET tube, and the potential then that you've corrected the mask leak because you put a tube in, and you don't know that you're now hitting the baby with way too high a pressure, and thus you'll deliver an excessive tidal volume. So you've got the volume trauma, the pressure trauma, and the potential for hypocarbia if you continue for any length of time, and reduction of cerebral blood flow. So we think there's a potential for, we need to get volume monitoring at the bedside, at interface between the what you're doing and the baby's movement of their chest, and that's where we're headed, really.
Okay, thank you, Mark.
Yeah.
And Murray, we've basically run out of time. I'm sorry. If you have any questions, please send through to Mark, Murray, or me on email. This is when he has his prototype ready for show and tell and for sale. I'm sure he'll be in contact. It looks brilliant. It looks like a little Apple Watch.
Well,
It's
please email us, or we're very happy to zoom in and chat further at any time with anyone. We're passionate.
Yeah, it's a brilliant looking device. For those of you on the call, if you're interested, at 2 p.m. Australian Standard Time this afternoon, we have a call about methamphetamines and long-term development from Tricia Waltz from Auckland. Cool. So feel free to dial in, and if you haven't got the link, just send me a quick text or an email. All right, thank you so much for stepping in at the very last minute. Thank you.
Thanks.
All the best. Bye, everyone.
Thank you.
Bye.
Thank you.
This is all recording. I'll send it round.
Thanks, Julie.
Bye.
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 Amazing, everyone seemed dropping off. Thanks, Julie. You still there? No. Everyone's dropped off. All right.